Good evening, everyone. How are you all? Welcome to First Aid AMC Clinical again. So tonight we are going to have our first class of the first 2 weeks free session, right? So we had our trial class just a few weeks ago based on psychiatry MSc. And MSc means mental state examination for those of you who did not attend that class. So we did a psychiatry class mainly focusing on how to take a psychosocial history. And also we also did a role play on that day, right? So you got a little bit of idea about psychiatry history taking, especially on MSc presentation. Tonight, we are going to do some role play on those topics that we have done. So this is a vital thing, as we keep on saying to you multiple times, that there is nothing more important than doing role play for this clinical exam preparation. So tonight we are going to do some of the most important cases related to that MSc. And this is going to give you an idea that how we normally take classes in our course, especially we do a theory like we did in the last week. That means that was our psychiatry MSc class, and that we call as a theory session. And after theory session, we do this kind of role play so that you understand how the theory usually works and how questions can come in your exam. This also gives you an idea that how you should prepare yourself, and you should do role play with your study partners. Again, initially it will be really hard because you have never done it before. And this is just your initial few months of preparation, right? And many of you just started clinical preparation after passing MCQ, maybe just last month. So it is very new for you, and we do understand that. So that's why we always encourage you to come forward and do the role play with us so that you learn from your mistake and we can give you some feedback on how you can improve. Okay, and in our course, when we will start after these 2 weeks, we will also show you some of the role play, especially we are thinking about that me and Dr. Cynthia can do few role play, and you can also learn from us that how you are supposed to do role play as well. But we keep these classes for the part of the course, so that will be after 2 weeks, not within these 2 weeks. Okay, so let's see how you are doing, and we can start showing the role play, giving you some feedback, and see that how you are doing at your own time, how much idea you have got about doing this role plays. Okay, let's start then. So for those of you who missed the initial class on our MSc presentation, I would advise you that please go through that class. The class recording is already given in YouTube and also in the Facebook group, which is your First Aid AMC clinical group. Okay, because there is a lot of posts nowadays in that group. It might lost with a lot of posts, especially about the course and the classes. What you can do, that there is a search option in the Facebook group. You just search by writing recording, and all the recorded classes that we have taken so far, it should come in your search at that time. So it's very easy to find out using the search box. Okay. So who wants to do the first role play? Dr. Paboda, yes, you can do it. Let me unmute you.
Yes.
Hi, Dr. Paboda, how are you?
Yeah, I'm good. How are you?
I'm good, thank you. Okay, so thanks for doing this. Let's give you a case. So what we are going to do is that normally you're supposed to get 2 minutes outside to read a case and 8 minutes inside to do the role play. But for the purpose of your preparation, we will always give you 1 minute to read and 7 minutes 30 seconds to do the role play. The other 30 seconds, we just keep it aside so that in exam, you don't get out of the time. Okay, so always when you prepare, 7 minutes 30 seconds is the maximum time you should prepare yourself, because many times in the exam, the other 30 seconds, it can run out. Many times it takes even 10 seconds just to start the case anyway. So prepare yourself as 7 minutes 30 seconds, but if you can do it within 7 minutes 30 seconds, in exam you will not run out of time, which is very important because you need to finish all the tasks to pass your station. Okay, so let's give you a case, Dr. Pagoda. Just give me 1 minute. I will just stop sharing this screen. So this is your case, your 1 minute time just started.
Okay. Let's see. Okay, should I start?
Okay, so just one thing I would like you to know, Dr. Pabuda, and everyone else who is listening, is that we are mainly focusing on online exam format, because as you might notice that this year most of the exams are online based and a few are face to face. In the course, we follow both face to face and online anyway, so that any of you who is going for any format, you know how to deal with that. But mainly when we do the role play, so today we are going to mainly focus on online and maybe a little bit face to face. Okay, so let's start, Dr. Pabuda. So this is your patient. Your patient name is Sarah. You can start.
Okay. Hello, good afternoon. I'm Dr. Paboda, one of the doctors in the hospital. May I confirm your name and age, please? You're Sarah?
Yes, I'm Sarah. My age is 30.
Okay. Nice to meet you, Sarah. So I understand that you are here because is this wife, Sarah? Patient?
Yes.
Okay. So I understand that you are here because of this trying to hang yourself. So before going to discussion, I would like to assure that everything between you and me will be confidential unless it affects you or others. Is that all right?
Yes. So, Dr. Pabuda,
Yeah.
We need to just make sure that in case of AMC, the role player that you get is just a single role player, which means in the question, it seems like that it is the wife has brought the patient, but there will never ever you will get wife and the patient in the same exam. So there will be only one person. Okay, so whoever will be here, it means that you are talking to the patient most likely. Okay, so let's just restart the case, which means that this case, the Sarah is the wife and Sam is the husband. So in here, you have got Sam to talk to you. Okay, so let's start.
Okay. Hello, good afternoon. I'm Dr. Paboda, one of the doctors in the hospital. May I confirm that your name and age, please? Are you Sam?
Yes, I'm Sam.
Yeah. Okay. Hello, Sam. Nice to meet you. I'm going to have to talk to you regarding your condition. So before that, I want to assure that everything between you and me will be confidential unless it affects you or others. Is that all right?
Yeah, that's okay.
Okay. All right. So All right. So may I know that why were you hanging? Like, why were you trying to hang today? How is your mood at the moment? Hello.
I just want to kill myself. That's it.
Yeah, I'm really sorry about that. So is this the first time you had tried to kill yourself?
Yeah, I wish I did it before.
I'm really sorry for that. So don't worry, because we are here to help you. So let me know that so do you had a plan to do it? A specific plan?
Anything. I just want to end this. I can't
Oh, all right.
live anymore. I don't deserve.
Okay. So is it why do you think you want to end your life? Is it that you hear any sounds from, like, do you hear anybody is talking to you, anything like asking you to do something?
Yeah, I can hear those narcissists telling me that I am the
So,
murderer,
mm-hmm.
and
Mm,
I know that I
okay.
am a murderer. I know I killed that patient.
Mm-hmm.
I could have saved her, but that little girl, she just died because of me. And
All right.
I should also die because I don't deserve to live.
All right. So don't worry. I'm here to help you. So I understand that you're feeling so. Okay. And then have you ever like see anything that others you don't usually?
Yeah, I, I can see that patient's the last moment I have seen her when she was dying
Mm-hmm.
was because of me.
All right.
It's just coming all my. I get the dream of it. I can see her dying, but
Mm-hmm.
I could not do anything to save her.
All right. I'm really sorry about the incident. So do you think that do you need a medical attention at the moment? So to with regards to your
No, I don't
condition?
need anything.
All right.
No, I
So
just want to die.
all right. So if you think like I will ask some silly questions, if there is a fire in this room, what would you do?
I will stay.
Sorry, I will stay.
Yeah.
Okay, all right, okay. So, and also some more silly questions to be spare with me. So, do you know where you are at the moment?
Yeah, in the
And
hospital.
okay, do you know who am I?
Doctor.
Okay, like, do you know what time is now and the date today?
I think it's Wednesday.
All right, okay. Um, all right. So, have you had any? Do you have any pain or anything?
No.
Do you have any feelings like to hurt others as well?
No.
All right. Um, okay. So I would like so I would like to present the MSE. Thank you very much for your history. So the patient appearance, actually I can't see. I think it's not well, not appropriately dressed, maybe unkempt, untidy. And the patient's behavior is like poor eye contact, but patient is cooperative. And the speech is slow speech with a low volume and a monotonous tone, a monotonous speech. And the mood is low and affect is low, so it's congruent affect. And there is perception of like hallucinations, visual and auditory. The patient has a delusion that he had killed the patient, and also so insight is poor and there is judgment is poor, and the cognition is oriented to time, place, but the date is not correct. So there's a high risk of suicide, but no risk to others. There is good rapport, and the history is not quite reliable. I would like to get the history from the family member.
Thank you, doctor. I think you still have got 1 minute time, which means that you were very fast with the history. It was good, Dr. Pavoda. I will just stop it here. Thank you so much for presenting the case, doctor. Now, what I felt about it, that I think it was a little bit quick in the history. Whenever you get the case is designed in a way that you should not get 1 minute time left, which means that something more we could have asked in the history, and a lot of other things was missed in the history as well. The approach is good, Dr. Pavoda, but we always want that confident voice when you actually start doing a lot of role play, you will get that confidence in your voice, that whatever you are asking, whatever you are saying, that has a confidence in it. That was a little bit lacking, but I do understand that this is very new for many of you. That's totally fine. But when you start doing a lot of role play, you will find that your voice shows that you are confident. Whatever you are saying, it seems that it's very right. And that's also very important when you are going for the exam. And it only comes after doing a lot of role plays. You will always understand, if you are an examiner, that who is the beginner and who has been doing this for a long time. It's very easy to find out that who did just like a few preparation and who did a lot of preparation when you are appearing the exam. And that's how examiner easily can pick up the right candidate to pass the exam. Okay. Now, Dr. Pavoda did it right, but few things we could have done in here, especially in terms of MSE presentation. We always ask you to follow the format, and that will help you not to miss any specific point from aseptic J3R. So what I would say in here is that there is no need to confirm the age of a patient or name of the patient in the exam. If in here, if it is already given that this is Sam who is presenting in here, so it's fine, it has been confirmed. We always do it in our real life scenario. We actually confirm the name, date of before saying anything. Now, it's not a bad idea to do it, but it's not must to do. So what I would rather do in this case initially, that let's say this is the Sam who is here as a patient. I would initially start in this way, that, hi Sam, this is Dr. Pavoda. I'm one of the doctors in this hospital. I understand that your wife brought you here today because you were trying to hang yourself. And I'm really sorry to know about your patient. I'm sure that you did your best to save the patient. I want to understand that sometimes things can happen in our profession that even though we do everything right, still something can happen. Still, we might not be able to save every patient in our hand. And that doesn't mean that it is our fault. I'm sure that you have done everything possible to save that patient. Sam, I would want you to understand that I'm here to help you. And if you tell me what's bothering you in a little bit more detailed way, I can obviously help you to show the correct path. And I want you to know that whatever I am going to discuss here today, it is confidential between you and me. I'm here for you until you are ready to talk. So Sam, will you please tell me that what exactly happened with that patient? I'm really sorry for asking that, because it must be very hard for you to recall that event. But I would like to know that what exactly happened. See that like your tone, the pitch of your voice, everything that I am showing you, it actually makes a huge difference. That you don't need to cry in front of a patient to show that you are empathic. And if you do cry, you will fail the exam, trust me. So the thing is that it's not needed that you become sympathetic to the patient. Your job as a doctor is to become empathic and show your empathy towards a patient who is suffering from major depression. So your voice, your posture, your way of talking, everything should show that yes, I also feel the same sadness as you. And I'm sorry that you're going through this. Okay, so that's important. That's actually changed everything. That's the main thing. The new candidate, the beginners or first time candidate, they usually don't bother about this type of thing because they think that they just need to finish the task in time, and if they can finish the task, they will pass the exam. It's never like that. A lot of time you you might not be able to finish the task. Still, you will find out that you passed that station. I still remember that I could not finish one station, but still I passed with a 7 out of, like, I think 7 by 7 in that station. So it was all about how is your approach. So it's always like that. It doesn't mean that if you don't finish that station, you will just fail. Sometimes examiner, they can like your approach a lot, even though you could not finish, still they can pass you. But if your approach is not right or empathic in the relevant scenarios, they would not be able to pass you. So the first thing that you need to understand is that how to approach. Approach is the most important thing. And there is a definite, like a separate task, and approach has a separate marking in every station. So if your approach is not right, they can fail you globally. A lot of candidates, they do everything, like their task is all done, they have touched key steps, but still they fail that station just because the role player said, no, I don't like this candidate. And your approach is, let's say, 2 or 3 out of 7, and your whole global score is 0. Okay, so let me tell you a little bit how the marking happens in the exam. So for this particular case, the marking would be, so first marking will be approach towards the patient. So that's first mark. Second, history. So MSE history is your second marking. Third is MSE presentation. And then a global score. Marking is from 0 to 7. So 7 is the highest. The thing is that many of you want to get 7. It's not needed that you get 7 in history and 0 in MSE presentation. You just need 4. If you get 4, you pass that station. So always I say that you don't need to get 7 by 7. You just need to get 4. So try to finish every task and get at least 4 so that you can pass globally. Okay. So in approach, let's say if you get 2 by 7, so let's say 2, MSE history, you have got 5, MSE presentation, you have got 3. So they usually supposed to make the global score based on the average of this mark. But if your approach is not good, if you don't in the approach, the likely chance, even though if your average mark shows that you pass this case, still they will fail you. Like maybe globally, they will give you 3 or 2. So the approach is very important, especially in psychiatric cases. All right. So next thing is, in this case, after you have done that, patient will open up with you. Patient will say, doctor, like this is happened. I was trying to save this kid, but I forgot to give her the appropriate medication, or I came late, and by that time everything already happened. So some kind of information you will get from the patient. Say, I'm very sorry to hear that, Sam. I'm sure you have tried your best. Then you start your format. So Dr. Pabuda didn't ask about the mood question, but when she presented the MSc, she said that mood is low and affect is congruent to the mood, which was wrong, because if you don't ask something in the history, never ever say that you did it in the presentation. the most important thing is being honest in the exam, because they easily can find out. So examiner easily find out what you have missed because they have been taking this exam for a long time. So if I can find out, examiner can find out within second. So, and in front of them, there is always all the key steps they know. So if you miss a key step, they will obviously understand that. So if you miss something, just say that I forgot to assess the mood of the patient, but the effect that I have observed, it seems patient is very sad and gloomy. So if you say that, you are fine. So once you have done that history, like initial presentation, patient opened up with you, you have given confidentiality, then you ask questions one by one. So remember the format, we ask mood, then we ask sleep and appetite question, then we ask suicidal risk question. After that, we ask hallucination question, all the delusion question. So don't forget to ask those delusional questions, because in this case, there were more delusion positive. So I was supposed to give you delusion of reference and delusion of guilt, which you haven't asked. So I did not give it to you. So if you ask me that, do you feel guilty of something? I would say, yes, I feel guilty about murdering this patient. If you would ask that, do you feel someone is talking about you? I would say, yes, the nurses in the hospital are always talking about me. So that's delusion of reference. Okay. So those things would be positive in this case. So if you are not sure that is it an auditory hallucination or is it a delusion of reference, you can directly ask the patient that, so do you actually see that the nurses are talking about you, or you just think about it? Okay, so in that case, if patients say, no, I have never seen them talking in front of me, but I know that they talk about me. I can hear them talking about me, but I'm not sure. I have never heard about it. So if that is the case, that means patient actually thinks that nurses are talking about him, but he has never noticed that. And that means he's hearing voices. But if patients say, no, I can hear them talk, they are talking about me, that means it's a delusion of reference. So getting a little bit of idea also important that what's the main finding. If you are not sure that is it a delusion of reference or auditory hallucination, you should ask more questions to be sure about it. So once you ask all the delusion question, then you go for insight, cognition, and judgment questions. If you have some time, you ask a little bit about the heads, SADMA, past medical history, just like how we have shown you in the format. Then you come to the MSE presentation. In the MSE presentation, you always make sure when your history is done, you thank the patient. So thank you so much, Sam, for all the information. Now I am going to talk to my examiner. Please stay for a minute, or please wait a little bit. I will come to you in a moment. So always take permission before you are starting to talk to the patient, to the examiner. So then you go to the examiner and say, dear examiner, I'm going to present mental state examination of my patient Sam, who was trying to hang himself with the rope because a patient died during his care. In terms of his appearance, I was not able to see the patient, so I can't comment on his appearance right now. So, but in exam, you should be able to see the patient, so you can comment. But for today, because you can't see me, just say that you can't see the patient, so you can't assess it. Then you talk about one by one all the aseptic J3R. So if you always write aseptic J3R in the paper, so you say that in terms of speech, it was slow and monotonous, but there was no disorganized speech. There was no rapid pressured speech. In terms of emotion, he said that his emotion was low and the effect that I have observed is congruent with his mood. In terms of perception, there was no auditory hallucination or visual hallucination. The thought form was linear. In terms of thought content, he had delusion of reference and delusion of guilt. Insight and judgment was poor. Cognition was intact. He is a high risk because of active suicidal ideation and also active delusion. He was answering my questions appropriately. So I was able to make a good rapport with my patient, but the history that was given to me was not reliable. So I would like to take a collateral history from the nurse or from the wife, sorry. So that will be your MSE presentation in this case. Okay, so if we go through this aseptic J3R, A for appearance, S for speech, E for emotion, P for perception, T for thought form, another T for thought content, I for insight, C for cognition, J for judgment, and 3 are, one is for risk, rapport, and reliability. If you haven't done our previous class, it will be a little bit tricky for you. We can't go back to that class and discuss the whole MSc because that was a whole class. I would suggest you to go to that class, hear the recordings and understand that class first, because this class is based on our previous session. Okay. And thought form is usually if you can understand a patient's conversation fully, and then we can call that it is a linear thought form. Linear thought form is normal finding. And we talked about what is disorganized speech, what is loosening of association, all of those. We will do some video presentation today as well, Dr. Nijatul. Now I can see some of your questions. So if patient is not making eye contact, should we try to talk without making eye contact, or we should try to look into their eye? Always look into the patient eye. But if patient is not making eye contact, respect that. You don't need to ask the patient to look at your eyes. And that's one of the finding, because most of the time depression patient will not maintain eye contact with you and they will look down while they're talking. The speech will be very slow. I was not that slow, but in exam it will be very slow. They will answer questions after giving like multiple pauses in between. So you have to be a little bit calm in here, and you can't push the patient to talk faster. This is how the patient is supposed to talk to you, because this patient is sad, right? So a sad patient will not talk to you frequently, will not give your answer just immediately. So you have to be patient with the patient in this case. How do we maintain the 8 minutes? So if this is a task in the exam, perform MSc and present MSc, 8 minutes you can divide as, usually I would say 6 minutes for the history and 2 minutes for MSc presentation. That's more than enough. Everyone is all good? Any questions with this case? Risk assessment has a lot of other things to consider, but if someone has active suicidal thought or is actively suicidal, that patient is already high risk. You don't need to do anything else on that. We will do some risk assessment case today, so you will see what are the other things that we look for. We would say, Dr. J, that give a little bit of introduction before MSc presentation. It looks good, but it's not must to do, okay? Thought form is something we say that if a patient is able to answer your questions appropriately, like every patient in the exam will answer your questions appropriately, because otherwise this case, they can't make this case. So most of the time thought form will be linear. So linear thought form means if a patient is answering questions appropriately and you can understand them, so their thought form is linear. Thought content includes all the delusional questions as we discussed. The time distribution, Dr. Farhana, I would say that in this case, 6 minutes for the history and 2 minutes for MSc presentation. All right, let's move on. Yes, that's fine, Dr. J. That if you forget to assess mood, you can always say that I forgot to assess the mood, but the effect that I have found seems that patient is sad and gloomy, or patient looks low to me. So affect is what you see in the patient. So you can always say that, and it's really fine. And Dr. Marija, in exam, you get 8-minute insight. So for this particular task, you will get 8-minute insight to do the whole case and 2-minute outside to read this question. Okay, so you get 8 minutes. In here, we are doing it as 7-minute, 30 seconds. But in your exam, you get 8 minutes for these two tasks. Great. Let's move on to the next. It will get much and much easier every time we do some role play. I know you have a lot of questions in your head, but trust me, the things will get much easier and the confusion usually will not last for a few days. Okay? Good question, Dr. J. If you think this is a depression case, do we need to ask all the depression M-side caps question? No need. Your task is not to give diagnosis and differential. The task is only MSE presentation. If the task is diagnosis and DD, then yes, you will need to ask all the depression question. But for this kind of case, you don't. And that's good. So Dr. Harris, that in online exam, there will be an examiner, but you can't talk to the examiner, which means that an examiner will be on the video, but you can't see the examiner. So there is always an examiner in your room who is assessing you during your exam, but you can't see the examiner and you can't talk to the examiner. So your task is to present it to the examiner, and examiner will be there. So you just present just like how you're doing now. Okay, who wants to do the next one, guys? And Dr. Marija, is there always a MSc case? Most of the time in psychiatry, you get a MSc case, but it's not always. You can get some other cases as well. Online exam can take a huge amount of time. So sometimes even 8 hours. So it takes a long time rather than face-to-face. In online exam, can we keep a note on paper? Yes. They allow you to keep a pen and paper, so you can write it down. So let's start with Dr. Mariam. So I will unmute you, Dr. Mariam. Mariam Amjad. Okay.
Hello, everyone.
Hi, Dr. Maria. How are you?
Good.
Good. Okay. Let me give you a case. Just hang on a second. So we'll do a video case. Okay.
Yep,
So
sure.
the video case is very much important in online as well as in face-to-face. So, and it's also easy in the exam because you don't need to take a history. You just watch the video and you present the MSc to the examiner. Okay. So let me show you the case first, and then we will start the video. So read the case and let me know when you are done.
Yeah, done.
Okay, so I'm going to show you the video now. And after that, when the video stops, you will get 2-minute time to present the MSc to the examiner. Okay?
Okay. I can't hear it.
Okay, should be able to hear now.
Yeah.
Let's start.
Hello, Robert Smith.
Yeah.
Thank you for coming to see me today. I'm Dr. Stanley. I'm one of the doctors that works here. Obviously, anything that we say is confidential between us and the team that I work with, and your GP who's asked me to see you.
Okay.
I hear there've been some problems with your housing. Do you want to tell me a little bit about them?
Yeah, I've had all sorts of problems. I mean, where do you want me to start? My neighbours,
Mm-hmm.
police, people spying on me in my street. None of them will admit to it, but my neighbours, it's mainly them at number 9, but I've seen them talking to the ones at number 6 and across the road as well.
So when did things start to go wrong?
I don't know. I mean, you'd have to ask them. Well, like when they started properly, like deciding that they wanted me out of the street. I think it was a few months ago. Months. It's been going on for months.
What makes you think they want you out the street?
Well, it's the harassment. It's the spying on me, putting bugs in my house, in my phone. And that at first they thought I couldn't hear it, but now they know that I know that they're there. Saying things about me through the window. Talking about what I'm doing. I know they're doing it. Whenever I leave my front door, woman at number 7, she's always there. She's clocking where I'm going and what I'm doing.
Why do you think they're doing that?
Well, I don't know. They just. I think they want me out.
Mm-hmm.
I think they're testing me, and they're trying to find out how far they can push me. Basically, it's all part of some test. I don't know why. I don't know what for. You'd have to ask them. That's what I've said to the police time and time again. I've said to them, why are you asking me these questions? Why don't you just talk to them?
You said that your phone was clicking. What was that about?
A landline.
Your landline?
Yep. Somebody rings me or I ring somebody. Between 7 and 10 seconds in, I hear click, click, click. Click, click, click every time.
Any other explanation for that?
I don't know. What else? Well, it could be, but every single time, and then they're talking to me, and then they know what I've been saying down the phone.
How are they talking? Where are they talking to you?
Well, I can hear them next door. Oh, he's on the phone again. Oh, he's reading that book again. I can hear them saying it, and they know that I can hear them, and that's why they're doing it.
Okay, so just to summarise at this point, your phone's something's happening to your telephone. You can hear your neighbours talking about what
Yep.
you're doing, making a commentary on your actions
Every day.
every day, and you feel that there's some sort of reason for all their actions doing this. Any other things that you've got problems with?
Following me down the street. People following me when I'm going to the shop. It's happening more and more. I mean, I've tried to explain to my friends about it. They get really agitated. They think I'm off my rocker, but they don't see it. They're not living with it every day.
Okay. So your friends are worried as well?
Yeah.
So
Well,
they're-
worried or I mean, I don't think they're on it. I don't think, but they know a lot about what's been going. I don't know. Maybe the police have been talking to them or something, or maybe my neighbours have been talking to them.
Okay.
I don't know. Again, you'd have to ask them. But it's hard. It's hard to know. It's hard to know who to talk to because they all, they're all involved.
So this started happening a few months ago. Has it had any other effects on your life,
Well, yeah.
such as?
Can't really go out. Well, I can, but I know what's going to happen if I do. So I'm just trying to stay low key. I'm trying to stay out of people's way. I've hardly slept. For the last. I don't know. I can't remember the last time I got more than 4 or 5 hours sleep.
So what disturbs your sleep?
I don't sleep until. I don't tend to go to sleep until after 2, 3. When I'm sure that they've turned everything off.
Right. Okay.
Downstairs, and just, you know, just can't, you know, I'm worried about it.
Any problems watching the telly, listening to the radio?
Oh yeah. They're using the TV as well. They're using all. They've got all this technology, obviously. I mean, I know there's all these smartphones and whatever now. You know, all they need is one of them, and they can just. But yeah, TV. You know, they've got the local news. If ever I watch that, you know, there's always some little comment. There's always something they say in there at the end about what's been going on. You know, pretty much every time I turn the TV on now. I mean, it's, you know, it's all just the cable, isn't it? So they could, for all I know, they've just plugged it into that.
What do you mean?
The cable TV, you know, it runs down the street. You know, everybody's got access to it if they know what they're doing. You know.
So obviously, this is all very distressing. All the different things that are happening. Can I take you back a little bit and just find out a bit more about you? I think your doctor said you're age 29.
Yeah, it's all right.
Tell me a bit about where you were born, your upbringing.
That's all. Okay, so now I'm going to give you 2 minutes to present the MSE.
Okay, just give me some seconds.
You can start.
Yeah. Hello, examiner. My name is Dr. Mariam, and today I have been given the task to present the MSE given on this patient in this video. So this is a 29-year-old male patient presented with the change in the behavior, and on appearance, the patient seems to be not well dressed according to the weather, and the speed seems to be rather fast and not monotonous. The patient was unable to make the eye contact with the doctor in the video, and there in the thought process there seems to be hallucinations regarding the neighbors and regarding the neighbors and the friends, and in thought content in the thought form there is delusion of precatory delusion and delusion of reference, because he was thinking that someone is spying on him and trying to bug him always. And the examiner was able to build a rapport with the patient and regarding and she didn't assess the risk. She didn't assess the judgment of the patient, but the patient told him or her that he was quite insomniac and unable to sleep, and he was unable to assess the cognition of the patient. So for me, I would like to continue. I would like to continue with the history of this patient and assess the mood, content, and further risk of suicide of this patient. And maybe, if depending on that, we will take on the congenital or collateral history. Thank you.
Thank you, Dr. Mariam. You did good. Okay, so see that the case is not very hard, but it's still sometimes it can be tricky because there's a lot of talking, a lot of information, but you need to pick up what is important for your presentation. So first thing is that to understand what they're saying, because that can get tricky in the exam, that it become hard to understand them sometimes. The second is to pick up those specific lines or specific words that is going to help you for MSc presentation. If you miss a single finding in this kind of cases, they might fail you because you're not taking any history. They just ask you to present the MSc by looking on a video. So they're very picky in this kind of cases, which means that any single important finding is missed, they fail the candidate. Okay, so you did good. What I would just add in here is that, let's say I would say in this way. So dear examiner, I would like to present mental state examination of this 29-year-old patient who presented with a behavioral change or whatever it is given. So in terms of his appearance, he is dressed appropriate to the weather because the doctor or assessor wearing some cold dressing, and he's also wearing the same. That means it's a cold weather, right? So he is dressed appropriate to the weather, well groomed. He was maintaining eye contact time to time, but he was sitting in a stooped posture and sometimes also having some fidgeting on his hands. So he was quite little bit of anxious and fidgety throughout the case. Okay, so I would say that. So in terms of his appearance, he was dressed appropriate to the weather, well groomed. He was maintaining eye contact time to time. He was sitting in a stooped posture and showing some fidgeting with his hands. In terms of his speech, it was a little bit loud and fast, but there was no slow monotonous speech or disorganized speech. In emotion was not assessed, but the affect that I have observed, it seems patient is disturbed. Okay. Then in terms of his perception, he was having auditory hallucination, but no visual or tactile hallucination. His thought form was linear, but the thought content, he had delusion of persecution and delusion of reference. The insight, cognition, and judgment was not assessed. In terms of his risk assessment, he is high risk based on his active hallucination and delusion, but it was not assessed if the patient had any suicidal thoughts. The doctor was able to maintain a good rapport with the patient, and the history was not reliable. So it is a good idea to take a collateral history from his neighbors. Thank you, examiner. Okay, so if you say something in that way, that will be the best idea. So the thing that you have missed, I would say that never just say that there was a hallucination positive. Say what type of hallucination it was. And then you did talk about persecutory delusion, delusion of reference. That was good. You told in delusion, you said in thought form, but delusion is actually in thought content. Thought form would be linear here. Okay. Yeah. So yeah, so you did good, but this is how I would advise any of you to present this kind of MSA.
So just one question regarding this stooped behavior and fidgeting. If we miss these things, because normally when we are listening to something, we don't focus on that. So if we missed something, can this cause resuscitation?
Not really, but I would say that they usually are very picky on the appearance part, because you're supposed to look into this kind of thing, that what is the actual appearance of the patient, what the patient is trying to show you. Is this patient looking anxious or looking manic to you, looking psychic to you? So what is actually patient is trying to say to you? There are cases where patient will look on the ceiling multiple times during the conversation. And if you miss that part, that patient was responding to some unseen stimuli, then they can fail you. But if you miss this part, like sitting in a stoop posture, looking anxious, it should be fine. They would not fail you for that.
Okay.
Okay. All right. Thank you. So how long is gonna be online exam? Okay, that I have answered. How long time in online exam, doctor? Role play is of same duration. Yes, the same duration for both face-to-face and online. Would we mention broadcasting? Yes, sorry to forget about that. So in case of thought content, there was another deletion as well. It was thought broadcasting. Not so much of withdrawal of thought, but there was thought broadcasting in this case, because patients say that TV newspaper is saying something about him all the time. So that was a thought broadcasting, and that should be also included in the thought content. So good question, Dr. Yu Huan, that how we know if the history is reliable or not. The easy way is that any patient who is having active hallucination or active delusion or loss of insight or having psychosis in a one word, that patient history is not reliable. So any psychosis patient who has active hallucination, delusion, or loss of insight, loss of judgment, we would not say that the history is reliable. History is not reliable for them. and you need to take a collateral history from whoever is available in front of you. It could be the nurse, could be the patient's relative, neighbor, friends, anyone. Video MSE case comes in face-to-face as well. And you can find this kind of videos in YouTube. Just search MSE videos or mental state examination videos in the YouTube. These are all from YouTube, so you should be able to find this. Not a huge amount of videos is available, but there are few which you can go through. Cool. Let's move on to the next one. So who was next to do the role play? Dr. Iman, you wanted to do? Yes. Let me unmute you. Now about
Yes.
the face-to-face, sorry, Dr. Iman, how are you?
Fine, thank you. How are you, doctor? Thank you for your effort.
No worries at all. Thank you for doing the case. So, Dr. Iman, I will give you the case in a minute. I'm just answering few other questions in between. So, someone asked in here that what's the recommendation for online and face-to-face?
Yes,
There is no
because my
specific recommendation. Yeah, there is no specific recommendation for it. I always say that it's up to you. Nowadays, you might not be able to get a face-to-face schedule anyway, because there is not much exam date available for face-to-face. So if you are looking forward to appear the exam this year, I would say go for online because it's easy to get the dates. But if you have been already preparing for face-to-face, then try to get the face-to-face date because you have already prepared for it. But if you're a new candidate, I would say prepare for online exam because we can see that AMC is going towards online exam because it becomes easier for them to conduct. That's what I feel. So I say that if you are good with with fluency in English, if you think that you are confident when you are talking, then online is the best idea because in online it's easier than face-to-face based on the physical examination because you don't need to do a physical examination on a person in online. You just need to say that this is what I'm going to do. But in face-to-face, you have to do it on a patient and you have to present what are the findings you have got, which can be tricky if you are not doing this kind of physical exam every day. Okay, so I would say that it always depends on you. There is no specific thing that passing rate is higher in online or face-to-face, more or less same. And Dr. Noor Morsheda, yes, you would say that this patient is in high risk based on active hallucination and delusion. This patient, Dr. Maria, this patient had a delusion of reference, not idea of reference, because everyone is talking about him, everyone is commenting on him, that delusion of reference. And Dr. Harris, we heard that there will be no online exam from this year. That was actually what we heard, because there is no more COVID going on nowadays. So the idea was that online exam will be abolished. There will be only face-to-face. But we can see this year that they have given more online exam than face-to-face. So we can never be totally sure on this part. It always depends on AMC. But I feel like AMC is moving towards online exam because it's very easy for them to conduct. And obviously that they don't need to like do a lot of things in the face-to-face. Face-to-face is hard to take even. So it's very hard for them as well to take the exam. So I would say like maybe they are moving towards online because it's easier and also cost benefit for them. Yes, so AMC can change your mode of exam from face-to-face to online. So it is the worst thing to do, because you have been preparing for something and they have changed it. So, but they always ask you before. So they would send you an email that this is what we are doing. They will not just change it immediately. It should not be like that. Okay, let's move on to Dr. Iman. We will give her a case. Okay, Dr. Iman, I am unmuting you.
Yes, thank you.
So this is your case. Your 1 minute time just started.
I'm ready.
Okay, just wait for another 30 seconds so that we can start the time. Okay.
Sure.
Okay, so this is your patient. Your patient name is Sam. You can start.
Okay. Hello, Sam. This is Dr. Iman, one of treating physician here at the surgery. I saw here your notes
Doctor,
that
you don't need to talk about anything, doctor. I just need to leave right now because I have a lot of things to be done. I know that you need to do your job because you have been asked to assess me by my counselor, but you don't need to do that because I'm totally fine. It's just like everyone is very jealous of me because they are actually not equal on my knowledge. They think that I'm just a 19-year-old. How I know all of these things? How I'm going to get the Nobel Prize because I'm going to work on the physics. I have a very brilliant idea that I'm going to win the Nobel Prize for it. I know how the string theory works, so I'm going to use that for all the physics model that so far we have got, but I have the best idea now. So I'm going to just use that and get the Nobel Prize. So school counselor, they don't have knowledge like me, so they just feel like I'm mad or insane for that. So please don't waste your time, doctor. Just let me go so that I can do these things for the universe, and the universe need me for these kind of things.
Yes, okay. I understand you. You are right, actually. And I'm here just to listen to you and talk with you a little bit, not to judge you. And I want to make sure that everything you will talk today with me will be between you and me. And I saw a lot of people like you, their school counselor bring them to me just to talk with them and to try to help them.
I don't need any help, doctor. I think like the school counselor, they need the help because they need to understand that a 19-year-old also sometimes can be superior to them. They can understand a lot of things that they don't understand. So I just ask you to just talk to the school counselor and just tell them that I'm fine so that I can do my job. I need to also do some more stuffs because there is a school gym which I need to work on. And I'm also needed to be in the drama club, in the music club because they're relying on me. So there's a lot of things I need to do right now. I don't have the time to talk on all of these things.
Yes, great. I appreciate everything. And I will talk, yes, to your school counselor. You are totally fine. I just want to speak to you, just asking you some questions, talking with you. No one will know that we are talking here. And I will talk with your school counselor as well. Is that okay?
Yeah, sure.
I will be here. Okay, I will be here until you are ready to talk. You are ready now?
Yeah, whatever. You are going to ask me anyway.
Okay, I'm pleased to hear that, Sam. I want just to know first, how's your mood now? What you feeling?
I feel really good because you can see that I'm really feeling good for a long time. I was not feeling like this. So I don't know what's
Yes,
going on, but I feel so good now.
I see. Great. Do you feel at any time in the home very sad?
No, I don't. I think like this is a very good time for me. I don't want to feel
Okay.
sad.
Okay. Do you have any problem in sleeping or appetite?
I don't need to sleep because I can stay all night. I feel very energetic. I don't even need to eat. So what is the point of doing that when I have that much energy?
Okay. I'm going to ask you some question now. It may seems quite strange for you. I'm sorry for that. Is it all right for you?
Yeah.
Okay. Do you think life is worth living?
Yeah, sure.
Okay, great. Do you have any thought to harm yourself or others?
No, why I would do that? I'm going to be like a celebrity. I'm going to win the Nobel Prize. So I need to
Yes.
live for that.
Okay, great, my dear. Okay, do you see or even feel or hear something that others don't?
No, why I would do that?
Okay. I just also want to make sure that if you think someone that trying to harm you,
No. But I
okay,
know
do you
that
think,
everyone is jealous of me because they can't even understand what I am talking about. So they're quite jealous.
okay, do you think people are talking about you?
All the time. They're talking about me in front of me. They're talking even if I'm not there. But I've never heard them talking about me like that. But I
Okay.
I can see that everyone is jealous of me. I can see that like they want to be like me, but they can't, right?
Okay. Okay. Do you think you have some social power?
Yeah, I have a special power. That's why I am superior to others.
Okay. Do you think that someone inserting or withdrawing thought from your mind?
No, I will not let anyone to do that.
Okay. And if do you think your thoughts are being broadcasted somewhere?
No,
Okay. And also you did not think that you need any medical help. Am I right?
no, no need
Yes.
of any medical help. I'm fine.
Okay. Uh, if we have here at the room fire, what you will do?
Is there fire in this room?
If I say if we have fire, what you will do?
Oh, I will run. I don't want to be in a fire.
Great. You know where are you now?
Yeah, in the hospital.
Okay. What's the date today?
Wednesday.
Okay. You know who I am?
The doctor.
Okay. Thank you. Do you have any stress at home or work?
No stress, but I feel I need to do a lot of things right now. So it is causing me stress a bit, but I'm fine. I can live with that.
Do you have social support enough?
No, no one wants to live with me because they're all jealous of me.
Okay. Did you smoke or drink alcohol?
No, but I have been doing a little bit more drugs nowadays because I can't just think like stop thinking about all these ideas. So sometimes I just go to the party, have sex with unknown people, and also just use some drugs.
Okay. Okay. Do you have any change in weather preference these days?
No,
Okay. Thank you. Thank you, Sam. I just want to talk to my examiner. Is that okay?
Yeah, your time is up. Sorry, doctor.
Okay.
You did really good. Okay, I'll give you time to actually do this one. You are doing really good. I'm happy with you're being very calm. That's very important in the exam. So yeah, so do the presentation, doctor.
Okay, sure. Dear examiner, I would like to present the mental state exam for my patient, Sam. He's a 19 years old university student referred to me by his school counselor because he has downgrading of performance. First, in terms of his appearance and behavior, he's well groomed, dressed appropriate to the weather, cooperative. Initially was not cooperative with me. He's maintaining eye contact time to time. He's showing some restless while he's sitting, and he was agitated at first of the time, but he started to be cooperative with me. For his speech, he was normal, a little bit rapid, but no disorganized speech. For his mood, as per the patient, his mood is good, and the affect I observed is congruent with his mood. And regarding his perception, there is no hallucination or auditory, visual, or even tactile hallucination. Regarding his thought, it was linear, no loss of association, but he has some delusion of in his thought, like he think that he has some paranoid delusion because he think that others jealous from him. And he's oriented to time, place, and person. He has good judgment, but he doesn't has good insight, as he doesn't think he needs medical help. He's not at low risk of suicide, no hallucination, no even thought of suicide attempt. I maintain a good report about the patient, and also but I need some, the history was not very reliable, so maybe I need some collateral history from his school counselor or family member. Thank you.
Okay, good job, Dr. Iman. Really good. So I think like you have covered everything that's actually needed. The only thing is that maybe we would not be able to take that much of a long history because you will be running out of time. So if it is only like MSc presentation, if you get your MSc finding, just move forward, because the head SADMA would not be like a really important. If you miss that, still you would pass the exam if you can present this finding to the examiner. So I would say that be a little bit faster with the history, but otherwise it's all good. So you might be thinking that in the history, should we ask all the mania questions? Now, again, because the task is not about giving diagnosis and differential, it's not that you need to ask all the mania questions. So this is a mania case, as you might understand. Mania cases are very hard in the exam. I was a lot better like in terms of like answering questions, but in exam you get like a real actor who would not allow you to talk. They will just talk and talk and talk. Just like Dr. Iman, at one point they need to stop. Like, how long I can talk without taking breath? So at one point, after 30 seconds, I have to stop to even to take a breath, right? That's your time when you go in and you start your questions. You never ever stop the patient conversation unless it becomes really bad that he's not stopping at all. Then you don't have any choice but to stop. But you will allow the patient initially to talk like Dr. Iman has done. But whenever the role player stop, immediately you should start talking. Okay, so that they don't again start talking. So many a case is really hard in that way because they just talk and talk and talk. And sometimes even they don't even sit still. They run around you, they roam around, they even sometimes wants to get out of the room. So it's a real bad situation that you can get in the exam. So only important part is being very calm what you are doing and very confident. Like Dr. Iman she did not even care what I was saying. That's actually the calmness that you need to be in the exam, which is really important, because if you don't remain calm, this role player can play you in a way that you will forget every format that you had in your head, and you'll just ask questions from wherever you can remember. So it will become a haphazard station. People fail these kind of cases, even though they know about this case, even though they have practiced it multiple times, still in the exam, like it becomes really hard. So being very calm and confident, that's actually the important part in here. So you start with your confidentiality statement and everything, then follow the format if you can, and just finish the case as we normally do. The mania has some other questions that we try to find out. Let me show you that. This is called Dig First. So Dig First is the mania questionnaires. So D for destructible. So patient becomes very destructible, doing a lot of activities at the same time. E for indiscretion. Again, a lot of things going on in the patient's head. G for grandiosity. F for flight of ideas. So flight of ideas is a very important finding in case of mania. Use this term in MSc presentation. Where you can use it? In thought form. A for activity increase. So lots of activities. Patient will say, I have joined in this club, drama club, music club, so a lot of activities at the same time. S for sleep deficit, and T for talkativeness. So patient will be very loud and talkative. You are supposed to get a rapid case. So main question that we asked, that the mood will be elevated. Patient will have decreased need for sleep. They will have increased energy. Okay. They will have increased spending. So if you ask question that, are you spending a lot? They will say yes. So gambling and like maybe investing in a lot of properties, lot of markets, business, etc. Increased sex drive, and they feel that they have a special power, which is that delusion of grandiosity. Delusion of grandiosity is the most important finding that you can't miss in this case, which Dr. Iman has missed. I know that she knew about it, but still she missed it during the MSc presentation. So this is one of the most important finding that you can't miss in a mania case. Okay. So now, do we need to ask all these questions? No need, because the task is not about giving the diagnosis, it's about MSc presentation. So as long as you have got all the questions for MSc presentation, you are good. All right. During the MSc presentation for this case, so appearance we can't talk about here, but most of the time in this case, patient will be very patient will look unkempt. Patient will be sometimes roaming around or running around. So you will be finding the patient like a little bit of fidgety kind of one. Okay. Then speech, most of the time it will be loud, talkative, rapid pressured speech. The one that I have shown, you can actually say it was a rapid pressured speech. And obviously there was no slow monotonous speech or disorganized speech. Then emotion, patient said emotion was good and affect was also congruent. In terms of perception, patient did not have any hallucination. Thought form was linear, but there was no flight of ideas, no loosening of association. Thought content, this patient had 3 delusions. One is the most important, delusion of grandiosity. Second, patient had a paranoid delusion, or we can even say delusion of jealousy, because normally delusion of jealousy is a subtype of paranoid delusion. So you can either say patient had paranoid delusion or delusion of jealousy. The third one was delusion of reference. I told that I think everyone in that class is talking about me. Okay, so that was delusion of reference. So these are the three delusion. Then insight was poor, judgment was intact, cognition was intact. In terms of 3R, patient is high risk. You can say moderate to high risk because of active delusional thoughts. And any acute mania patient is always high risk because you need to admit this patient to the hospital, even if it is involuntary, because they are high risk to themselves and others. And then obviously you were able to maintain a good rapport and the history was not reliable because this patient did not have any insight and also having delusion. So you need to take a collateral history from the school counselor or maybe friends and any other relatives. Okay, thank you, Dr. Iman. You did really good. I'm happy with your presentation.
Thank you.
Thank you. So let me go through the questions. So how do we know about patient's clothing here? You can't, because you can't see me, but in exam you should be able to see. Okay, and then you can comment on that. Doctor, can we ask from how long he is feeling so? It's a very good question, Dr. Atia. In any psychiatric case, we should always ask about how long you're feeling this way, especially to make a diagnosis. To call it mania, we need at least a week of this symptom. To call major depressive disorder, at least we need 2 weeks of those symptoms. So duration is a very important thing. We should always ask it. And we can also ask that, have you ever had it before? So, and also we should rule out the possibility of feeling low at any time to rule out bipolar disorder. So those questions you can ask. It's not a bad idea. And Dr. Marija, there is no way you can actually know how long you are taking to take the history because you can't see the watch. And this actually comes with long and lot of role plays. When you do a lot of role play, you will know that you are running out of time. And that comes as a, like, it's kind of an experience that you know that you are running out of time and you will move towards the next task. And no, Dr. Pereira, if patient already says that my mood is really good, then we don't need to ask it again. Okay, so if something we get from the patient, then we don't need to repeat that. This patient did not have flight of ideas because in that case, you would not be able to understand anything. In online exam, Dr. Larray, you would be able to see the patient on video. So you would be able to know the clothings, you would be able to know the eye contact, everything you would be able to know because you will be able to see the patient. Do we need to ask heads in this case? No need. If you're running out of time, forget about it. In this case, mood was good. And affect is also, yes, the patient looks actually good, right? So affect is congruent. There is no need of mentioning about the sleep in aseptic J3R. We just keep it as part of our format, mood, sleep, appetite, suicidal risk. This actually gives us the depression part of psychiatry. There was no flight of ideas, Dr. Farrell. Do we have to say anything if the patient is roaming around? What to do in that situation? Very good. So I would always say if a patient stands in front of you, you should also stand. Okay, so stand and then ask the patient, I understand that you need to go, but please sit with me so that I can finish it as soon as possible and then you can go. I'm assuring you that I'm not going to take a lot of time of yours. I'm sure that it is very important for you. Okay, so say something nice and they will usually listen to you. So in this case, emotion, whatever patient says, when you ask the question, how is your mood these days? If patient say, I feel very good, then you say that patient emotion was very good. So it's what patient says when you ask the question about their mood. Yes, Dr. Mariam, you should be able to see the patient clearly. You should be able to see the clothing and appearance as well. If they're sitting on a stoop posture, you should be able to see that. If you can't see it, you don't need to comment on it. Very easy. And they don't also expect that you would comment on those things. There is no stopwatch or timer in online or face-to-face. No, Dr. Hassanul Kabir, you are not able to have a look on the computer clock. This is actually will be an illegal thing to do in the exam. If somehow they understand that you're doing something like that, they can fail you and you might be completely banned from taking AMC clinical exam forever. I would say that please do not attempt something like this so that all the dreams, all the hard work that you have been doing, it's just for nothing. People for a long, long time have been passing this exam without watching the time, and you will be also able to do that. So don't worry on that. Start doing the role play and things will become much easier because everyone had done it. You should be able to do it as well. Delusion of persecution and delusion of paranoia is same. So Dr. Maria, so should we say mood is really good and affect is good too, which is congruent with the mood? So you would say that in terms of his emotion, his mood is really good and the affect that I have observed is congruent with his mood. So that will be the sentence that you should use. Yes, Dr. Pramodia, when you join the course, we will allow you to join in some of the groups where you should be able to get role players. So you get partners for role play from our course. Okay, it should be fine. There's a lot of students who join this course, and there's enough people who are looking for role players. So it's not very hard to get a role player. Doctor, why you say no flight of ideas? Patient was talking about a lot of things, I guess. The thing is that it was, yes, Dr. Farid has answered that they were relevant to the questions asked. Did I go from one questions to another and did not answer the examiner question? No, I did answer the question, right? If I don't answer the question and I just talk and going from one topic to another, so then we can say it's flight of ideas. But if I give relevant answers, if I'm answering questions properly, then it's not a flight of ideas. In flight of ideas, you would not be able to even talk with the patient. They will just talk and talk. You will not get your answer anyway. Okay, so if you get your answer, it means there is no flight of ideas. We did discuss about what is the difference between flight of ideas and circumstantiality, tangentiality, Dr. Afrin. Please go through our class on that, which we have done that. And there was a lot of explanation about how to differentiate between these topics, okay? Please go through that so that you can understand it clearly. All right, guys, so that should be it. Let's move on to the next case. Who wants to do the next one? Dr. Farhana? Okay, great. Let's unmute you.
Hello. Hi, doctor.
Hi, Dr. Farhana. How are you?
Yes, I'm fine. How are you?
I'm good, thank you. Okay, let me give you this case. So your 1 minute time just started.
Okay.
Now I have added one other task for you. So just when you present MSE to the examiner, also discuss the risk assessment of this case.
Okay.
Okay. All right. So your 1 minute time just started.
Okay, doctor, I can
All
start.
right. So this is your patient. Your patient name is David. You can start.
Okay, thank you. Hi, David. I'm Dr. Farhana, one of the GP here. Very nice to meet you. I understand from the note that you are here for the venous ulcer over your medial malleolus and you are roaming around on the street. Let me assure you that
I'm not here,
whatever.
doctor. So I actually did not need to come in the hospital. It's just the police who are very bothered about this. You
Okay.
can actually let me go because I don't need the treatment for it, and I don't want to as well. So if you can please
Okay.
discharge me and just let the police know that I'm fine, then I will be really grateful.
Okay, I understand, David. I will definitely see what is happening, and I will assuring you that I will not take too much time, and I will whatever we talk today will be between you and me, and will be very much confidential. Are you with me so far? Can you please cooperate with me for a moment?
I'm being cooperative with you, doctor. And you're saying
Yeah.
that you will not tell anything with the police. So whatever I'm saying to you,
Yes.
you'll not
Yes.
disclose that
Doctor,
to the police.
Yes, I understand. I will not disclose anything to the police. Please be assured. And David, can you please tell me how's your mood today?
I was feeling okay, but now I feel really bad and I feel very disturbed because I was not doing anything around this street. I was just roaming around. I didn't do anything bad. So why did the police
Okay.
brought me here?
What exactly happened? Can you please tell me?
Nothing. I was just roaming around and just walking around, and suddenly I can see the police car stopped and they just took me here.
Okay, okay, I understand. And how's your sleep and appetite?
Yeah, it's okay.
And how you got this venous ulcer in the food?
What is venous ulcer? I don't know what you're talking about, doctor.
Sorry, I am talking that how did you get hurt in your food? Can you please tell
I
me?
have something on my food. I don't even
Yeah.
notice that. I'm not sure
Okay.
actually what happened over there.
Okay, I understand. Okay, and how can you please tell me that is it? Do you think that your life is worth living? Don't misunderstand me, and just a routine question.
Yeah, I want to live.
Okay, and do you have any passing thoughts of suicidal tendency or harming yourself or others?
No, why I would do that? I am the messenger of God. I want
Yeah,
to help people.
okay, I understand. It's a very good. You are the messenger of God. Now, can you please tell me that you can something you can hear, see, or feel anything that others don't?
I don't know if others can, but I can hear God. He's always talking to me.
Okay, and can you see God?
No, he is very busy. He can't come and show me, but he always
Okay.
talk to me.
Okay, okay, I understand. And do you think that someone is spying on you or trying to harm you?
No one can harm me because I have the power.
Okay, and do you think that someone is controlling you
No,
and talking about you every time?
yeah, I can understand that all people in the street are always talking about me.
Okay, and do you think that you are guilty for any reason?
No, I'm doing good thing. I'm helping people. I'm trying to reach people so that they understand the good in this world.
It's very good that you are doing good. And do you think that someone is inserting or withdrawing thoughts from your mind?
No,
Okay, and do you think that your thoughts are being broadcasted to any media like TV, newspaper, or radio?
no, but I think sometimes God send me message through TV, newspaper. So
Okay,
obviously something is happening on that.
okay, okay. And do you think that you need some medical help?
No, why I would need medical help where I have my God.
Yeah, I understand. It's very good. And if it's a routine question that if there is any fire in this room, what will you do?
Nothing. Fire can't touch me.
Okay. And where are you right now? Can you please tell me?
I'm in the hospital.
What is the date today?
I don't know, doctor. I don't need to know that because I've been doing a lot of other things. I
Okay, I
can't
understand.
keep
You are
pace all
doing
the
great.
time.
Oh, okay, okay. And do you know who I am?
You're the doctor?
Okay. And how is the home situation? Do you live with
I
any
don't
other
have any
else?
home.
Okay. And
No, I
do
live
you
in the
work?
street.
Okay. And do you work?
No, yes, I'm working on the good of people. I'm working for God.
Okay, I understand. And do you smoke, drink alcohol, or take any recreational drugs?
No, I don't have any money to afford that.
Okay. Do you have any past history of mental or family history of mental illness? Any other things?
No.
Okay. Okay. Thank you, David, for your cooperation. Now I would like to present my findings to the examiner. Thank you. Dear examiner, my patient David, who is the 47 years old man and caught by police, and he is having venous ulcer over the medial malleolus and roaming around the street. And on his appearance, he is unkempt and disheveled, and he is also cooperative, and he is maintaining eye contact also. And there is he is distracted and seems to he is restless and agitated. And on regarding his speech, he has pressured speech and rapid, and his mood is normal, and which is congruent with his congruent with his mood. Affect is congruent with his mood. And on regarding perception, he has auditory hallucination. And regarding thought form, there is a loosening of association is present. And also there is no tangentiality or circumstantiality and no concrete thinking. And there is also, I see that there is flights of and there is also, I see flights of ideas. Okay.
But continue.
Okay, and regarding thought content, he has a delusion of grandiosity and delusion of grandiosity and delusion of uh, delusion of grandiosity. And on cognition, he is oriented with the time, place, and person. And his insight is good. His insight is good. And on regarding judgment, it is poor. And risk assessment, it is not assessed. And he can maintain a good rapport with me. And the history he has given is not reliable, because I need some collateral history from the police also. And regarding the risk assessment, I want to say that he has no suicidal or homicidal tendency, and I think it may be a case of drug abuse or something like that. And I need some collateral history along with to find out the reason, exact reason of this. Thank you, examiner.
Thank you, Dr. Farhana. You did good on the history. It's a really a good history taking. I was happy with that. But the MSc presentation, there was like some missing part, and also like some of the findings was wrong. But as a whole, I'm happy what you did. Okay, Dr. Farhana. So the history, nothing to be added. You're doing really great on the history part. But I think like the best idea is that write aseptic J3R on the paper. Okay, and then when you are getting the findings in your history, just write those findings in front of those aseptic J3R, because you did ask a lot of questions, but you did not actually comment on that on your MSc presentation, which means that you missed to write those findings in your paper. That's why you could not remember that what was the finding. Okay, so let me say that what were the findings that in this case.
Doctor, I have one question that is in online exam. If it is impossible to write something in our paper or any sheet, and because we cannot remember everything. Whatever. Sorry.
No, it's fine. They allow you to write on a paper, so you can have one pen and a paper in front of you.
Okay.
That's they allow.
Okay.
Yeah, so you can write it, but you can't write it in the 2-minute outside. You have to write it in that 8-minute time when you go in and when you start your history taking.
Okay. Okay. Thank you, doctor.
Okay. So in this case, we can't comment on the appearance. Then come to the speech. So speech in this case, you said about that it's a rapid pressure speech. It was not a rapid pressure speech. It was just a normal talking, right? I did not like show any rapid speech or loud speech. Okay, so it will be like a speech was normal in tone, volume, and quality. Okay, but there was no rapid pressure speech or disorganized speech. Then in terms of emotion, it was good, and the affect, you can say that affect was congruent with the mood. P, perception, there was auditory hallucination. Thought form, you say that there was loosening of association. There was no loosening of association. You could understand everything that I was talking about. So the thought form was linear. Thought content. So thought content in this case, there are 3 things that you have found. One, obviously you told about delusion of grandiosity. Then the other one was delusion of reference, that people are talking about me in the street. And another one, that TV newspaper has a message from God. So that's thought broadcasting. Okay, so these 3 will be our finding in thought content. Then you have insight, which you said good, but insight was not good because I said I don't need any help, right? So insight was poor, cognition was intact, judgment was poor. In terms of 3R, you actually did risk assessment in your history, but you say that you did not do risk assessment, but actually you did. How? Because patient has active hallucination and delusion. Then patient did not have any financial support or social support because he is living on the street. He doesn't have any financial support. He's having like trouble with money, as he said, right? And if you also see that patient was having lack of insight and lack of judgment. So active hallucination, active delusion, lack of insight, lack of judgment, lack of social support. These are all high risk criteria. We will discuss what are these criteria we are talking about. And then you are able to maintain a good rapport with the patient, but the history is not reliable. So you would like to take a collateral history from the police. So that will be your MSc presentation. About the risk assessment, let me see if I have got that. Just one second. Yeah. We follow the SAD person's scale for risk assessment. So what this is mean? So S for male sex. So male sex itself is a high risk. A for age, anyone more than 44, less than 20. D for associated depression, previous suicidal attempt, excess alcohol or substance abuse, rational thinking loss, which is loss of insight, S for lack of social support, O for a organized plan of suicide, no spouse, that means no social support, and S for sickness, any other kind of like organic condition associated with this. So this patient, if we score 0 to 4 is low risk, 5 to 6 medium, 7 to 10 high risk. Now you don't need to measure that. You don't need to say like patient risk assessment score is 7. You don't need to do that. You can always just find out if it is a low risk or high risk patient. High risk patient means patient having active suicidal thought or homicidal thought, active hallucination, active delusion, lack of insight or judgment. These are the most important high risk criteria. Okay. Apart from that, lack of social support, financial support can be also something that you can add. What are the low risk then? Someone who doesn't have any active suicidal thought, active hallucination or delusion, having good insight or judgment, they are low risk. Okay. So that's how you talk about the risk assessment in this exam. Any questions, guys? Okay. When presenting things, how we keep all in memory with missing any fact? You write things. That's Dr. Anus. If you don't write the findings, you will miss it. So there was no pressured speech, right, Dr. Farhana? Dr. Mariam, doctor talked about loosening of association. There was no loosening of association. I think mood in this case was disturbed, as the role player said he is disturbed. No, when you asked about the mood, actually patients say that I'm okay. So mood will be okay. Thought broadcasting mean that patient thinks his thoughts are being broadcasted. It is something like that. So we call that thought broadcasting means if a patient thinks that his thoughts are getting broadcasted. So normally, whenever we get the finding that something is related to TV newspaper, we can still talk about thought broadcasting. Ideally, thought broadcasting actually means that if patients' thoughts are getting broadcasted. So in this case, it is like 50-50. If you don't say thought broadcasting, it's fine, given that the patient says that like God is sending messages through TV and newspaper. So it's like a 50-50 thing. We would not be that much bothered if you don't say thought broadcasting in here. Do we need to ask the duration of hallucination here? Yes, we should ask about the duration in any questions. And Dr. J, in exam, if a patient answer your questions, which they need to do for the purpose of exam, in real life, these cases become a lot worse. That means you might not even understand anything. They would not answer any questions of yours. Then yes, you can say that there is abnormal thought form. In exam, if you understand their questions and they are answering your questions appropriately, thought form should be linear. We don't say it's loosening of association. Loosening of association means if I ask you, how is your mood? Patient says, well, I was in the movie today. That book is really nice. Oh, I was driving yesterday. No, there was a fish in that pond. Yes, I just need to read that book. No, yes, my girlfriend called me and I missed that. So what's happening? There is nothing in relation to each sentence that I am talking about. That's loosening of association. And you have never got the answer, right? There is subtype of loosening of association, which we call tangentiality and circumstantiality. Circum, think about circle. So that means I'm saying a lot of things, but at the end I said, yeah, my mood is not that bad these days. So that means it's circumstantiality. In tangentiality, patient will never ever answer your questions. They will just talk and talk. Okay. Yes, ulcer, like this patient having a venous ulcer and patient even don't know about it. That's also you can talk in the risk assessment. You can always ask with the open-ended question, Dr. Ajra, but in psychiatry, they don't want to talk about things. Okay, because as long as you don't give the confidentiality statement, they might not give you any questions answer. So I always start with asking questions that I understand that police brought you here. Can you tell me a little bit more about it? So that way you can say, okay, if patient did not answer, then you can always say that, say those confidentiality statement and then move forward. We should not take a detailed history of ulcer. That's not a relevant task in this case. You can only say that, I'm very sorry to know about your ulcer, or you can say lesion. Patient sometimes don't understand ulcer. You can ask, I'm very sorry to know about the lesion on your leg. I'm going to take care of it as well once I finish talking to you. Is that okay with you? So you can just say that, and that will cover that part. But you don't need to ask full history about the ulcer. And flight of ideas, as we discussed it in our last session, this class is actually about role play so that you can learn more about role play rather than discussing the same theory again. So flight of ideas means that if you ask a question, patient will not answer it properly. Rather, they will jump from one topic to another, but making a little bit of association between each thing that they're saying. That means if I say, how is your mood? Patients say, oh, I think I'm going to watch that movie. That movie was fantastic. No, I also read a book about that movie. That book was really good. I think I should buy that book, which means that everything that I am saying, there is association, right? But little bit later, but still I'm jumping from one topic to another. Okay, so that's what we call as flight of ideas. It's not needed. If patient doesn't say to you that, are you going to tell these things to the police? You don't need to say that, I'm not going to tell it to the police. You don't need to say that. And yes, you are not legally bound to say anything that you discuss with this patient to the police until police gets a court order. Then you might need to do that. So it's a confidential statement, and it will be confidential between you and the patient. Ulcer is a medical jargon, yes. Family history of mental illness, it's appropriate to ask. We ask these questions. It's not something which someone feel very judged. There is no better way to ask these questions. Because if you think that patient getting a little bit judged, you can always say that any family history of someone who had some mental health issues. So you can ask mental health issues. That also sounds good. Okay. Yes, medical jargon should be avoided every time. Yes, Dr. Jahara. In this case, patient was oriented to time. Patient was oriented to place and person, but not the time. That's right. Like Dr. Rabia, you are not legally bound to say this to the police, right? And but obviously, if the patient says that I want to kill someone, then that consent or confidentiality doesn't remain valid anymore. So then you can obviously break this confidentiality. Okay, so that's all about your questions, guys. I think we wanted to do another case today, but we are running out of time. So that's all good. We should finish here tonight. If anyone wants, we can do a video role play. Okay, and then we can finish this. And about the course, just ask it at the end and we can answer you. Okay, Dr. Fatima and others. Dr. J, you want to do it? Yeah. Okay, let me unmute you.
Good evening, sir.
Good evening. How are you?
I'm fine, sir.
Okay. All right. Let me give you a case. So this is the case. Read it, and when you are done, just let me know. Then we will start the video.
Yeah, we can start, sir.
All right. So let's just start.
Hi Andy, do you want to come on in and have a seat? I'm Dr. Taylor, I'm the on-call psychiatrist for this afternoon. I got a call this morning from your family doctor because I think you went to see him this morning along with your mum, and I gather that things have been a little bit difficult for you. You've had some rather distressing experiences. So I think your doctor thought it might be helpful for us to have a bit of a discussion about that to see if I could help. Would that be all right with you?
No, it's fine.
Would it be all right, Andy, for you to tell me a little bit about what's been going on?
Well, you're going to think it sounds stupid, but my housemates are working for MI5.
Right.
And they're doing stuff to my brain.
Okay.
And they're out to get me.
Okay. That must be very difficult for you.
Okay.
How long has this been going on for, Andy?
About 2 months.
Right. And how did you first work out that this is what was happening?
I came home one time and they'd moved the TV to the other side of the room,
Right.
and I knew then
And what was it that you knew at that moment?
that they were for MI5.
Right. Okay. Okay. So it's been going on a couple of months.
Yeah, this new lecturer started at uni,
Right.
and he works for MI5. And
Right.
he basically drafted my housemates in, turned them
Okay.
against me.
Okay. Okay. Now I've noticed a couple of times while we've been talking that you've sort of looked round you into the room as if you're checking for something. Could I ask you what's happening at those times?
Well, I can hear them talking about me.
Right. Who is it you can hear?
My housemates.
Right. So that you recognise it as their voices?
Yeah, I can hear them all the time.
Right. How many voices can you hear, Andy?
3. There's 3 of them.
Okay. And do they sound real, like my voice sounds talking to you now?
Yeah, it's odd. It's like I can hear them when they're not here.
Right.
And
So what they're not when they're not in the house with you?
yeah, it's like they're in the other room or something.
Okay. Okay. And can you hear what they're actually saying?
Yeah, they're talking about me.
Right. Okay.
They're always talking about me.
Okay.
They're always commenting on everything that I'm doing.
Right. Can you give me an example of what they would say?
Well, like if I'm packing my bag to go to uni or something, they'll comment on that, like he's
Right.
left the house now, or,
Okay. Okay.
you know.
Anything else? Do they ever talk to each other, perhaps about you?
Yeah, that's what they do. I mean, and now they know. They've sort of twigged that I know about them now,
Right.
and they're saying like I'm making trouble.
Okay.
And and that they're going to sort me out.
Okay, okay. What about actually talking directly to you in the way that I'm talking to you now? Does that ever happen, Andy?
No.
Okay. So you've been hearing the voices of your housemates. Have there been any other changes? Have there been any changes perhaps to the way you're thinking? Sometimes people tell us that their thinking changes in some way. So, for example, they might feel that they're getting thoughts put into their head that aren't their own. Have you had any experiences like that?
Yeah, I do think things that aren't me. Like
Okay.
they're putting stuff in my brain. It's not me. It's not. I'm not thinking.
So different thoughts in your brain.
Yeah, it's
right.
like it's stupid stuff as well. It's like the other day I suddenly just started thinking about some woman in Coronation Street. I don't watch any of that crap.
Right. It's not your kind of thing normally. Right.
They're not my thoughts.
Right. Okay. And do you have any idea how that's happening, or who's responsible?
It's MI5. It's this chip they've put in my head.
Right. Okay.
And I can feel it all the time.
Okay. So you're getting thoughts put into your brain that aren't your own. What about a different sort of experience? What about the experience that somehow other people are able to know what you're thinking, even though you haven't actually told them?
No.
Nothing like that.
They're just putting stuff in my head.
Just putting stuff. And can I just check, Andy, as well, that you're not getting the experience when your thoughts just stop altogether, like you have no thoughts left?
No. If anything, there's too much in there. I wish I could unplug it.
Okay.
Just get this thing out of my head.
Right. And you mentioned this chip or this device in your brain. Do you want to tell me a bit more about that?
Well, it's a tracking device, so they know where I am at all times, and that I can feel it moving around, like rotating
so you
around.
can feel the physical sensation in your brain. Okay. That must be very difficult for you.
I don't know why they're doing this to me. I've done nothing wrong.
Okay. Can I just check, are there any problems, Andy, with the rest of your body? Any changes in sensation or any bits that feel different in any way?
No, I feel fine. I'm not ill or anything. I just want this thing out of my head.
Okay.
That's all. So you have now 2 minutes time to present this case.
Dear examiner, I have performed mental status examination on the 21-year-old Andy, and in examination I have found that in appearance he is well dressed and well groomed, but looks a little bit sad and somehow worried. He was able to maintain eye contact, but in between he was responding to some unseen stimuli, and in the speech was almost normal, but sometimes it is fast. In emotions, mood was not assessed, but the affects looks like worried. And in terms of perception, he has auditory hallucinations, which is commanding. And according to him, it was 3 persons were talking about him. In terms of thought form is a delusion of persecution, and delusion of reference is seen. Apart from that, thought insertion is also present. And according to patient, the chip, they have inserted chip in the brain, and they are tracking and rotating inside the brain. Apart from that, insight was not assessed, cognition was not assessed, judgment was not assessed, but looks like it impaired. And as the patient has active hallucinations and delusions, so it is high risk for self and for others. The doctor was able to maintain good rapport with the patient, and the patient's history looks like not reliable, so it is necessary to take collateral history from his family members or other medical staff. Thank you.
Great. Thank you, Dr. J. It was really good. You did actually said everything. Just one thing. Anyone else who can say what was the one thing that Dr. J has missed? We would not say about insight, cognition, or judgment because it was not assessed. Yes, tactile hallucination. Okay, that was the one thing, because patient says that I can feel the physical sensation of the chip rotating around my head. That means that is a tactile hallucination. Okay, so all other findings, Dr. J, you have said is all good. Very good that you actually say that on appearance, patient was responding to some unseen stimuli. The speech in this case, you can say like normal, sometimes a little bit slow. Then emotion was not assessed, so patient, but the affect seems to be disturbed. Then perception, we talked about auditory hallucination and tactile hallucination. Thought form was linear, and thought content, patient has delusion of persecution or paranoid delusion, delusion of preference, and thought insertion. All of you said. And then insight, cognition, judgment was not assessed. In terms of risk, patient is high risk because of active hallucination and delusion. The examiner was able to maintain a good rapport, and yes, it's not a reliable history, so it's a good idea to take a collateral history from others. Okay, very good.
Thank you, sir.
Thank you, Dr. J. There was no delusion of control. When it was asked, he said no, someone is controlling me or something like that. And Dr. Pramodia, yes, there was a paranoid delusion, which is the same like persecutory delusion. Is there any specification about taking collateral history from? Not something like that. Anyone who is accompanying the patient, you can take collateral history, especially for someone who doesn't have insight or who has active psychosis, their history is not reliable. So we should take a collateral history from someone who is sane. The pressured speech was the mania case that we have done today. That was the pressured speech. Okay. So if a patient is having mania-like presentation, then we talk about pressured speech. So it will be very rapid, talking and talking, very loud. So that's pressured. Yeah, this is a psychosis, right? Patient having for 2 months, patient having these hallucinations, delusion, that's a psychosis. If we don't know if someone is accompanying the patient, you just say that it's a good idea to take a collateral history from the patient's friends, relatives, or neighbors. So just give a generalized idea. Okay. Thought insertion is when patient says that I think like the thoughts are not mine. Like the last night I was thinking about the women in the Coronation Street, but that's not my thought. Okay, so that's thought insertion. If patient thinks that someone inserting thoughts in their head, that's thought insertion. Thought broadcasting means that if the patient thinking something and that thought is getting broadcasted in the TV newspaper, that's thought broadcasting. Yeah, we normally say that if speech is normal, we say that speech is normal in terms of rate, volume, and tone. It was a thought insertion, not thought control, not a delusion of control. Delusion of control means if the patient say, I think someone is controlling me. Everything that I am doing, it is not me who is doing it. Someone is controlling that. So that's delusion of control. All right, guys, so we should stop here tonight. Do you guys have any questions about the course? So this is actually one of the role play sessions that how we do it. In our class, we do role play on theory. We do role play on random cases as well. There are few random cases in your schedule, I think. At least I think there is one with Dr. Cynthia. Let me have a look when it is. 2 with Dr. Cynthia. One is 11th May and 14th May. So then you will see how the random role play sessions work. And then on Saturday, 6th of May, you have our theory sessions on cardiology. So you will get an idea how our cardiology sessions looks like. Come and join the session. We will have 2 sessions on cardiology. And then after that, we will do a role play on cardiology as well. So my exam is after approximately 6 months from now. I want to join the course so I can have access to the notes and previous recording early before free sessions. You can do it. if any of you have exam and you have an exam date this year, especially we say that if you have it like before finishing the course, then yes, we can give you access to our previous batch recording. Okay, you can go through that in your own time. And same with Dr. Fatima, especially if you have exam date already, then we should be able to give you the access. But I would say that the thing is, if you only just go through the recorded classes, rather than joining the live session, doing the role play, it's also not very ideal. For someone who has exam date, that's ideal because they don't have time. But if you are a beginner and you want to just like watch the recording and read the notes, prepare by yourself without coming to the class, doing the role plays with us, that's not actually the ideal way to prepare. I would say if you are a beginner, please move on with us. Do the classes with us, and gradually do everything that we are doing. There is already 90 videos of role play sessions already in your portal. So if you think that you have some more time, you can always go through those recorded sessions. Get to know the new cages of Dr. Cynthia, who has discussed all the cages throughout the last few years. So that you can do. But I would say if you're a beginner, please make sure that don't just go through the recorded classes. Come to the class, do the live sessions, get to know each other, find steady partners. So that's ideal way to read. But if you are going for exam, you have an exam date already this year, then please reach to us. We should be able to give you access of our previous batch. Now, in online exam, Dr. Maria, there is no specific time. It can take 3 hours, it can take 8 hours, because there is a lot of break in between. Sometimes online exam can take a long time. Even just for a whole day, online exam can go on and on, because it's a technical thing. And then they usually do a lot of check in between the exam, before the exam. So it takes a huge amount of time for conducting this. But the cages are same. There will be 16 cages, but it takes a lot of time to take the online cages for them. So next session is about cardiology, Dr. H.A. And Dr. Fatima, I think I have answered your questions. And Dr. Win, marking in AMC Clinical, as I said, that the marking has specific areas. The task that you have in each of the cages, that actually gives you the marking. So when they mark you on your approach from 0 to 7. If you get 4, then that's passed in that step. Then if the task is history taking, then take physical examination from examiner and management. So all of this has specific marking from 0 to 7. So if you get 4 in all of those tasks, then globally you can get 4 and you can pass the station. Okay, we will discuss a lot about this marking in our orientation session. So then you can also know about it much better. So recording, we are adding all the recorded classes already in your portal. If you are the part of a course, then you should be able to access that. It's only for our course students. Okay. Yes, so all the classes are recorded. So if you miss any classes, you should be able to get the recording in the next 24 hours. Random role plays doesn't have any specific topic, but what we are going to do initially, once the course starts, because still the course hasn't started for the students only, because this is still the free session. Once course starts after these 2 weeks, then we are going to tell you what are the topics of random role play, so that if you want, you can go through those topics by yourself, and then you can at least get some ideas. The portal activation can take 1 week because there is a lot of students at the same time they are sending messages to us. It takes a little bit of time for our team to give you the whole access. So we say at least wait for a week. And again, if you are waiting already, just send us a message or an email that this is your email in your portal. You have already made an account. Can you please activate my account? Then the team member can activate it if you're in the queue. So the course fee, we discussed that it is $899 Australian dollar and the duration is 5 months. I can't give you the exact day, Dr. Annie, but I can say that the course will finish after 5 months, which should be end of September, if I'm right. So if we have started in this month, so if you just measure 5 months from this month, that should be it. We take mini mock exam, which are not 16 station mock exam, but small exam during the course and at the end of the course. But if any of you needs to take the full mock exam, which is the 16 station, that has to be done separately. No, there will be a lot of other psychiatry classes. There is 3 more psychiatry classes, Dr. Naidu, but that's part of our course. For a fresh beginner, Dr. Pereira, I would say keep at least 6 to 8 months for your preparation. And yes, you can join late, but I always say that if you are actually preparing for clinical, join at the beginning of the course. You become much more oriented rather than joining in the middle. But we allow anyone to join in the middle as well, if that is what you want. And you can go through the recorded classes if you have missed any of this. Our only physical examination course is $200. The class schedule. So Dr. Nijatul and every one of you who are actually thinking about the course details, please go through our course details from the Facebook group, because we have been giving the course details in the Facebook group every day. Okay, so I would advise you, if you please go through this First Aid AMC clinical group, then go to the featured section of it and go through these details. Everything is written in here. Everything that you are asking, we already have written everything. So the new here, when the 2 weeks class is started, what the course actually included. Okay, we also talked about the cost, duration, 3 days a week, even when the classes are taken. So everything is written in here. So please go through these details and then it should be fine for you to know. Okay. And you can always just send a message to us and we can answer any of your queries, even if you don't get this from these writings. Okay. The course has been started and our physical examination course starts after 2 months of this course. So if we have started this course in May, so you are looking for May and June. In July, first week, our physical examination class will start. Course, you will get access to the note until you pass the exam. No, Dr. Iman, previously what happened is that there was not much of an online exam available. At the end of last year, online exam was very, very less. People could not get online examination. So we recommended everyone that go for the face-to-face because there is a lot of face-to-face exam available. Okay, so that was the main reason of recommendation. It's not about which is better in terms of passing rate. It's about availability. Because if you are trying to get into the exam and you can't even appear the exam, there is no point of preparation. Now there is not much face-to-face available, but there is a lot of online exam. So that's why we recommend if you can go for online. But if any of you already prepared for face-to-face, then no need to change it. Just go for what you have prepared. Okay. This course has already been started from today. So this is actually the course class also. So you are actually doing our first 2 weeks of the course class. But we still allow any of you to join the course. So if you're still waiting for joining, just send us a message in my messenger or send us email. And you can always get into the course within this 2-week session. Yes, Dr. Go, 6 to 8 months for beginners. And yes, if your exam is November 30, this 5 months preparation should be enough for you. But obviously you have to give everything for your preparation. How can we get a study partner? So once you are part of our course, Dr. Iman, then we actually help you to get some role players as well. Now, obviously, you have to find it by yourself. We will give a pooling system to find out the where, like the time and place of people who are looking for study partner, just same like you. And once you know that someone is appropriate for you to be a role player, you have to reach to them. We can't actually ask someone to be your study partner. You have to reach to them and make an arrangement so that both of you are mutually agreed. There is no exam in December or January. It's usually in November. And how much is study time for beginner? There is no specific time for it, Annie. You know best how much time you actually need for your preparation. That is actually up to you. Some people can take things very easily within even just listening to the class. They don't need to even read things. So there are people like that. There are people who needs more time to get all these things in their memory. So it's all about how you are. So if you think you are a slow learner, then you need a little bit more time of preparation by yourself. If you're a fast learner, then you don't need much of a time apart from listening to our classes. All right, guys, so let's stop it here tonight. We'll talk more about, so mini mock exam, it depends on how much students actually are going to appear the exam. We have a lot of students, but not everyone wants to appear the exam. So it depends on if we get a huge amount of candidates who are appearing for the mini mock, then it might be 1 or 2 cases. If it is like a very small amount of people, then we increase the number of tests. Okay. There is no specific case that we actually have in our mind for mini mock test. But mini mock test is mainly to assess how you're doing with the course, what kind of improvement you can do. It's obviously not a full mock exam, and we can't do that. Our course fee is very minimal. And if we need to take 16 stations for everyone, that's actually not cost effective for us, right? So I hope that you guys understand that. Any idea about type of visa to take exam face-to-face? I am not sure about this. That should be a visitor visa, about like most likely that's 600. Okay, so let's stop it here tonight. I know you have a lot of questions, guys, and I really love to answer all of these questions. But obviously, throughout this 2 weeks course, you can ask any questions that you have in your head, and we'll try our best to answer it. Okay, take care, everyone. We'll see you again in the next class. Have a good night. Bye.